Hello, my name is Giancarlo Lange, and I'm going to speak about brentuximab vedotin with chemotherapy for stage 3 or 6 Hodgkin's lymphoma. Okay, starting with the introduction, brentuximab vedotin is an anti-CD30 antibody drug conjugate that has been approved for relapsed and refractory Hodgkin's lymphoma. We are going to see a video.
Basically, the scientific rationale to develop this type of trial is the fact that ABVD, which is the standard of care for advanced stage Hodgkin lymphoma, so the combination of erythromycin, bleomycin, vinblastine, and carbazine, is not able to cure 100% of the patients with this disease. So we have some of them who are primary refractory, others that relapse, and there has been a lot of scientific activity trying to improve the results of what we consider the standard of care. Knowing the results or the efficacy of brentuximab vedotin, which is a monoclonal antibody drug conjugate in the relapse setting, the idea was to combine brentuximab vedotin with a modified version of ABVD, so basically omitting bleomycin, and to compare this experimental protocol with the standard of care which is ABVD for these patients. And this is the rationale for the ECHELON-1 trial, which is a prospective clinical trial that compares head-to-head in patients with Hodgkin lymphoma advanced stage, ABVD, standard of care per 6 cycles versus brentuximab vedotin ABD per 6 cycles. The primary objective of this study was the modified progression-free survival, and evaluated by the independent review facility, and the study is positive in the sense that the modified PFS in the experimental arm was significantly better, evaluated at 2 years, than the modified PFS of the ABVD arm.
Okay, continue with this position. We're going to talk about the method, how this investigation was done. Okay, they conduct an open-label, multi-center, randomized phase 3 trial involving patients with previously untreated stage 3 or 4 classic Hodgkin's lymphoma, in which 674 were assigned to receive brentuximab vedotin, doxorubicin, vinblastine, and dacarbazine. The name of this is A more ABVD. And 617 were assigned to receive doxorubicin, bleomycin, vinblastine, and dacarbazine, ABVD. The primary endpoint was modified progression-free survival, the time to progression's death or not completed response, and use of subsequent anti-cancer therapy, as adjudicated by an independent review committee. The key secondary endpoint was overall survival. So continue with another video.
Brentuximab vedotin with chemotherapy increased the survival rate of patients with Hodgkin's lymphoma. Hodgkin's lymphoma is a type of cancer and has been treated with stable frontline regimen, doxorubicin, bleomycin, vinblastine, and dacarbazine. Bleomycin was determined to have fatal pulmonary toxicity, which created a need to find a new regimen. Brentuximab vedotin, an anti-CD30 monoclonal antibody, was added to the stable regimen, replacing bleomycin, and evaluated for improved efficacy and reduced toxicity. The objective of the study was to evaluate the survival rate of patients undergoing chemotherapy with brentuximab vedotin drug for Hodgkin's lymphoma. The study was a open-label, multi-center, randomized, phase 3 study of sample size 1,334. The inclusion criteria in the study was: patients aged 18 had history of classic Hodgkin's lymphoma and without any history of chemotherapy. The patients with any other cancers, pregnant women, cardiovascular conditions were excluded from the study. Patients were randomized into two groups, A plus AVD and ABVD group. Modified progression-free survival rate was the primary endpoint, whereas overall survival rate was secondary endpoint. Interim positron emission tomography scans were obtained at the end of cycle 2 and end of treatment. The efficacy outcomes were significant in A plus AVD group, progression-free survival rate of neutropenia and peripheral neuropathy has improved in A plus AVD group. The study concluded that A plus AVD regimen is more effective as the frontline treatment of classic Hodgkin's lymphoma.
Okay, we'll continue, and we're going to explain about the results. At a median follow-up of 24.6 months, 2 years modified progression-free survival rates in the AVD and ABVD groups were 82.1% and 77.2% respectively, a difference of 4.9 percentage points. 3 were 28 deaths with A more AVD and 39 with ABVD. All secondary efficacy endpoints trended in favor of A more ABVD. Neutropenia occurred in 58% of the patients receiving A more ABVD and in 45% of those receiving ABVD in the A more ABVD group. The rate of febrile neutropenia was lower among the 83 patients who received primary prophylaxis with granulocytosis colony stimulation factor than among those who did not. Peripheral neutropathy occurred in 67% of the patients in the A more AVD group and in 43% of patients in the ABVD group and 67% of patients in the A more AVD group who had peripheral neutropathy had resolution or improvement at the last follow-up visit. Pulmonary toxicity of grade 3 or higher was reported in less than 1% of patients receiving A more AVD and 3% of those receiving ABVD among the deaths that occurred during treatment. 7 of 9 in the AVD group were associated with neutropenia and 11 of 13 in the ABVD group were associated with pulmonary-related toxicity. Another video.
Yesterday I presented the results of a clinical trial that was promoted by the Gel Tamo Group and funded by the Takeda company. That was a trial with a new regimen for Hodgkin lymphoma patients in the refractory and relapsed setting as an induction prior to induction of response prior to transplantation, to autologous stem cell transplantation. Most patients with Hodgkin lymphoma are cured with the first-line therapy, but there is still 20 to 30% of the patients that cannot be cured with the first attempt. For these patients, we need a different approach that includes at this moment reinduction therapy with polychemotherapy and autologous stem cell transplantation, and patients achieving complete response do very well. But most patients do not achieve complete response because the conventional regimens provide a median complete response rate about 30% as a mean. So with a new approach would be the use of new drugs in combination with the conventional chemotherapy, and this is the case. We have combined brentuximab vedotin, which is the new drug, a new monoclonal antibody that has been used in Hodgkin lymphoma with good results in the past, but we want to use this new drug in earlier moments. So this is just second-line therapy before the transplantation. We combined brentuximab vedotin with etoposide, zolumedrine, high-dose RC, and cisplatin, which is a regimen very popular in Spain for these patients. With this regimen in the past, we usually obtained 50% of complete responses, but with the new regimen, we hope to increase the complete response rate. The regimen was given 3 cycles before the transplantation, and with this regimen, with a reasonable toxicity, not higher than the usual toxicity that we saw in the past with the conventional regimen, we increased the complete response rate from 50% to 71%. All patients that attempted collection of stem cells succeeded. In total, 64 patients collected sufficient number of peripheral stem cells for transplantation, and we finally could transplant 60 patients with a Bing regimen in the chemotherapy. The transplant succeeded in all patients. There were no engraftment failures, with a median recovery for neutrophil counts of 11 days and 12 days for platelets. And the final results were increased up to 83% complete responses after transplantation. Finally, the progression-free survival was high, 71%, with a time to tumor progression of 74% at 2.5 years, and an excellent overall survival of 91% of the patients alive after 2.5 years of evolution, with a median follow-up of 27 months. The results are good, are encouraging, and since it was a simple phase 1-2 trial, now we want to develop a phase 3 trial comparing in a randomized manner and prospective manner the old chemotherapy with this new combination.
Okay, and for end, we are going to about the results. Okay, ABD has superior efficacy to ABVD in the treatment of patients with advanced stage Hodgkin's lymphoma, with a 4.9 percentage point lower combined risk progressions, death, or not complete response, and use of subsequent anti-cancer therapy at stage 3. Okay, that was all. Thanks for watching.